The topic for today is Renal, and we are going to have a CCS session. The speaker that we have here is Dr. Nikhilesh Jain. He's a director and operational head depth of critical care services care at CHL Hospital Indore. So you may take over. Thank you.
Okay. So you've got a 34-year-old male who presents to the emergency department with severe muscle pain, dark colored urine, and generalized weakness for the past 24 hours. Feel free to interrupt if you think that you have not got the question. Now, he reports completing an intense CrossFit workout 2 days ago, which included multiple sets of weighted squats and deadlifts. He denies any prior history of similar symptoms. So I'm going to add some more details in this. So vital signs are BP is 125 by 80 mm of mercury. Heart rate is 98 beats per minute. Temperature is 37.3 degrees centigrade and respiratory rate of 16 breaths per minute. He is alert and oriented, appears uncomfortable due to muscle pain. He's got a bilateral thigh and calf tenderness with mild swelling. No focal deficits, normal deep tendon reflexes. Elevated serum myoglobin levels and serum creatinine levels are seen with low urine output. And this is the color of the urine that's been put on the side. So what do you think is this?
Rhabdomyolysis.
Yeah. This looks fairly clear and easy. This is rhabdomyolysis. The type of questions that can come out of this is, and the type of offshoots that can go out of this is, so what is the diagnosis has been well answered. Basically, there is a list of electrolyte abnormalities which are seen commonly in rhabdomyolysis. One, so you need to know all about them, especially with reference to your calcium disorders, phosphate disorders, everything. And at what stage of rhabdomyolysis are they seen? That is one. What is the diagnostic test? That is something you need to know. You need to know whether there is any role of urinary alkalinization. You need to know drug-induced causes of rhabdomyolysis and list the complications of rhabdomyolysis. In addition to that, you can have an offshoot wherein they may ask you about the timing of renal replacement therapy. It can go on to that tangential. It can go on to a tangential of definitions or various criterion for defining acute kidney injury. Am I clear? So we go on to the next CCS. You've got a 72-year-old male with a history of hypertension, type 2 diabetes mellitus, chronic kidney disease stage 3, presents to the emergency department with chest pain radiating to his left arm. An urgent coronary angiography with contrast was performed and it revealed a significant coronary artery disease. When we look at his past medical history, he had hypertension, he had type 2 diabetes with a HbA1c level of 7.8%, CKD stage 3 with a baseline serum creatinine of 1.6 milligram per deciliter, and the medications he was on was metformin, lisinopril, aspirin, as well as atorvastatin. He did not have any allergies, and in the recent procedures, he has undergone a contrast-enhanced CT angiography about 2 weeks ago. So these are his vital signs: BP of 138 by 84 mm of mercury, heart rate of 76 beats per minute, respiratory rate of 18, and temperature of 36.9 degrees centigrade. On general examination, there was no distress. Patient is alert and oriented. Cardiovascular point of view, there are no murmurs or no signs of heart failure. Renal point of view, there is no costovertebral angle tenderness. There's a mild bilateral lower extremity edema. 48 hours after the coronary angiography, the patient reports decreased urine output and generalized weakness. The baseline creatinine, which we went through the earlier slide, which was 1.6 milligram per deciliter, has climbed up to 2.3 milligrams per deciliter. That is a 48-hour increase by about zero point 0.7 milligram per deciliter. You've got a blood urea nitrogen of 38 milligram per deciliter, which is elevated. There is mild hyperkalemia, 5.2 milliequivalent per liters, and urine analysis shows muddy brown casts with no proteinuria. So can anybody tell me what is happening here? You can put it in the chat
Contrast,
box.
contrast-induced nephropathy, perhaps leading to rhabdomyolysis and generalized muscle weakness.
Why you are thinking in terms of rhabdomyolysis here?
This generalized weakness is also there,
So
and
can it
there's
not be a
muddy
part
brown
of
casts.
worsening of renal dysfunction? There's nothing to indicate in the history here that that this patient has rhabdomyolysis. I would definitely grant you contrast-induced nephropathy. So what are the type of questions that again you are going to look at? So what is the diagnosis? Told very clearly. So can you establish a causality for the same and what are the risk factors? So you need to know the risk factors for developing contrast-induced nephropathy. One, can you establish a causality? Causality meaning, can you establish the fact clearly that this is happening because of the coronary angiography and the contrast exposure? You need to know certain risk prediction models, especially the Roxanne-Mehran risk scores. You need to know the preventive measures, including hydration, role of N-acetylcysteine, certain other measures, how they do it, and any correlation with other contrast agents in the sense, what would be something that you would like to use? You would like to use isoosmolar, would you like to use hyperosmolar, hypoosmolar? And how are the type of contrast agents going to fare in terms of being a causative etiology for acute kidney injury for this particular subgroup of patients? And what would be the sort of evasive measure that you would like to use, especially in a patient who has undergone coronary angiography with a background of CKD, right? Next case vignette, just put your answer in the chat box. A 28-year-old woman, gravida 2, para 1, presents to the emergency department 1 week postpartum with complaints of severe headache, confusion, bruising, and dark colored urine with a history of normal vaginal delivery at 39 weeks without any complications. Now, vital signs include a BP of 148 by 92 mm of mercury, heart rate of 110 beats per minute, temperature of 37.2 degrees centigrade, and respiratory rate of 18%. On general examination, the patient is pale, mildly jaundiced, alert but confused. Neurologically, this patient is disoriented to time and place, no focal deficits. Skin is suggestive of multiple petechiae and ecchymosis on the upper limbs. And abdominal examination tells you about soft, non-tender uterus, which is well involuted. So what do you think you are looking at here? Any guesses?
Postpartum eclampsia or pre-eclampsia.
Okay, everybody seems to get towards help. Okay, so let's see what happens here. We go on to the next slide. So you get a platelet count, which is 18,000 per microliter, severe thrombocytopenia, with hemoglobin of 8.2 grams per deciliter. Schistocytes on blood smear. You've got an LDH value of 950 units per liter, which is elevated. Haptoglobin is undetectable. Creatinine of 2.1. Acute kidney injury. Indirect bilirubin is elevated. Coagulation studies are normal. And you've got an ADAM TS13 activity, which is less than 10%. So do the answers change now? They do. Answers now have changed. Correct. So the moment I put ADAM TS13 activity, suddenly it becomes very clear what we are talking about, right? So in this patient, you need to know about the diagnosis. You need to know about the pentads, tetrads, and all those things. You need to know about the confirmatory test and how well to define it. Where all can you get a false positive and a false negative? You need to know the algorithm, specifically the pregnancy specific algorithm for validating that this patient is indeed having a TTP related to pregnancy. You need to know the treatment for the same, how long you want to do the treatment, how many sessions you want to do. Are there any special precautions that you would like to use? And of course, the differential diagnosis which can come out of this, right? This can
Sir,
also
if
be
we
even
are not, sir, if
yeah.
we are not given the ADAM-TS levels and just the clinical vignette, then should we be able to, I mean, then
Still, TTP would be one of the differentials here. Did you look at the overall symptomatology? I'll go back to the slide. Just look at this. You know, this patient had neurological problems, right? This patient had skin issues. This patient had thrombocytopenia. This patient had a MAHA, you know, schistocytes on blood smear. So she had a microangiopathic hemolytic anemia. She had evidence of hemolysis in the form of LDH. She had acute kidney injury in the form of elevated creatinine of 2.1 and indirect bilirubin elevation. Coagulation studies were normal. Even if I do not mention the ADAM TS13 activity, it is very clear that we are looking at one of the differentials of TTP very likely. Right?
because MAHA is there and AKI is also present with neurological features, so we should think of TTP. That's
Yeah, you have evidence of hemolysis as well, no? LDH 950. Do you think that with a normal PTT fibrinogen D-dimers, you would have thought of it as DIC?